Good afternoon, and welcome to our 8th COVID-19 webinar. I am your host, Edward Halprin, the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of the Touro College and University System. There's a familiar trope for recurrent broadcast events. It's a variation of thank you for joining us, thank you for tuning in, welcome back, see you next time. We've all heard them. And these tropes are designed to make the viewer feel welcome and good about tuning in. But it seems rather hollow, doesn't it, to say things like welcome back when the raison d'etre for us coming together is to share knowledge about an unremitting, raging pandemic that appears well on its way to taking the lives of over 300,000 Americans. At New York Medical College in Touro, we set ourselves the task of providing you with the most up-to-date and objective information about the pandemic. For our 8th webinar, we've invited back some speakers you've met at previous webinars and some new members of the NYMC Touro family who you've not met before at our webinars. We're going to hear from Dean Robert Amler, Dean of the School of Health Sciences and Practice at New York Medical College, about can the family get together for Christmas or New Year's or Hanukkah or Kwanzaa. We're going to hear from Dr. Sherlita Amler, the Commissioner of Health of Westchester County, about what the limits are of the powers of public health officers in the pandemic. We're going to hear again from Dr. Mille Etienne, who spoke to us a few webinars ago about taste and smell abnormalities from COVID-19. He's going to tell us about this new research, which you may have seen on the front pages of the newspapers, about proposed nasal sprays to inhibit the attachment of the virus. Dr. Kathleen DiCaprio, a frequent audience favorite, will be back to tell us about what we need to know now about vaccine development. And Dr. Tammy Hendricks from the Touro College of Osteopathic Medicine is here to talk with us about a topic raised by my wife, who asked me, do you think that childhood language development is going to be interfered by the fact that babies are going to see their parents' faces covered with masks, and they won't see facial expressions, and they won't see the lips moving? Will that inhibit the ability of children to learn how to speak in a timely fashion? Another audience favorite is back with us again, Dr. Marissa Montecalvo, who's going to talk with us about whether we're on the verge of having several million Americans with a pre-existing condition, that is prior infection with COVID-19. And then we'll conclude our panel discussion with someone you haven't met before at these webinars, the chairman of the Department of Medicine at New York Medical College, Dr. Neil Schluger, who was the senior author of the lead article in the New England Journal of Medicine a few months ago about hydroxychloroquine. He's going to talk with us about hydroxychloroquine and remdesivir, about what we're supposed to believe of whether they are or are not useful. Then, after our panel discussions and our formal presentations, we'll go to questions and answers. So remember to look at that little box on the bottom of your screen where it says Q&A and type your questions for us, and we'll monitor them as the sessions go on and try to get to as many of them as possible during our Q&A session, which will be moderated, as is in our previous webinars, by the president of the Touro College and University System, Dr. Alan Kadish. Now, let's turn our attention to some housekeeping matters. For those of you who are seeking CME credit, the phone is 828-295-1144. That's the number you use to send a text message and type in your attendance code 22SLOB. The letters are all in capitals. Send a text message with 22SLOB to that phone number. And if you don't want to do that, go to our website, www.weds.com, and click on the sign in button and also put in that code 22SLOB. And in either case, if you do that, you'll start getting information about how to fill out your satisfaction questionnaire with our webinar. And also you'll get information about how to click the right boxes to get your CME credit. It can all be done electronically. Maybe you want to take out your cell phone and take a picture of this slide, or maybe you want to do a screenshot, or maybe you want to write it down. I'll be back later during the webinar to repeat it, but there's always someone who writes in the message, whoops, I didn't get the information. So here it is for those of you who want your CME credit. Next, I'd like to talk with you for a moment about how we finance these webinars. We say these webinars are free, and they are. And we say the CME credit is free, and they are. But that's, of course, not quite true from the standpoint of New York Medical College in Truro. We have to pay for the hard work of all the people in IT who create these webinars technically for us, do the recordings and broadcast for you, as well as the members of the faculty and all that slide preparation, the work of the librarians to create the basic material for the preparation of the slides. So we hope that some of you at this time of year, when it's time to think about your charitable donations before the end of the year, will think about giving back to New York Medical College for this webinar. Your tax-deductible gift to support these webinars and our research in COVID-19 may be supported by visiting the website, as you see on the link, www.nymc.edu/give, and how you can give to the college, www.nymc.edu/give. And for those of you who prefer good old-fashioned checks can be made out to New York Medical College and put on the memo line to support the COVID-19 webinars, and they can be mailed to our Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. I hope also you'll do a screenshot of this or take a picture with your cell phone or write the information down to support our programming. Thanks for listening. Welcome to our webinar. And now we'll hear from Dr. Alan Kadish, the President and CEO of the Truro College and University System, to launch our program and get our speakers started.
Hello, I'm Dr. Alan Kadish, President of the Truro College and University System and President of New York Medical College. Welcome to the 8th New York Medical College Truro COVID webinar. Our first webinar on January 31st of this year happened before there were a significant number of cases in the United States. And we've continued to update the public on what we think is cutting edge information about COVID-19 through the past few months. As you can see from this slide, COVID cases began to be reported in March. There was a little peak in the spring and then in the summer, but we've now reached a new peak with perhaps a slight decrease in the last few days. There are over 250,000 deaths, and we've just hit a record number of hospitalizations. And although the average is below that, there are a couple of days where we've hit 200,000 new cases of COVID-19 in a day. This pandemic is not under control. What about in the New York metropolitan area, where we're very proud of the way we responded to the peak in the spring? We're not anywhere near the spring number of cases, but new cases are clearly increasing, and we risk a recurrence of the severe situation that happened in the spring if we don't address this carefully. So as we've done throughout the past few months, today we're going to try to update you on where we are and where we might be going, and determine if there are ways we can more quickly get this pandemic under control. First, of course, there's some exciting new news about vaccines. 2 vaccines, both messenger RNA vaccines, have been submitted to the FDA for emergency use approval. A 3rd vaccine, made by AstraZeneca, released a complicated large-scale clinical trial, and whether that vaccine will be ready for approval soon still remains to be determined with a more careful look at the data, but we'll hear an update on vaccine development today. We've also learned a lot more about COVID-19 in special situations and about long-term adverse consequences from infection. We'll talk a little bit about that today as well. Finally, the public health system and the healthcare system in the United States has been stressed and continues to be stressed by the COVID-19 pandemic. And we'll hear from one of our really important public health officials the county commissioner of Westchester County, where some of the earliest outbreaks happened, about what it's been like to try to deal with this pandemic and how we can make some progress going forward. In summary, there's great news on vaccines, and there's concerning news about the fact that the number of cases continues to increase. We hope that today's educational program will help the public understand where we are and help us put in place measures to finally get this pandemic under control. Welcome, and thanks for coming today.
Hello, I'm Dr. Robert Amler. The question to be answered is, how can we get together while staying apart? Specifically, everyone's asking this holiday season, because it is the season, how do we get together for Hanukkah, for Christmas, for Kwanzaa, for New Year's Eve, and for New Year's Day? Well, we know by now this is how we stay healthy despite COVID. We have to block the exposure. When there's no exposure, there's no infection. No infection means no illness, and no illness means no risk. But it's easier said than done, as we are all learning, because how do you really defend against a breath, even though we know this is what we have to do? So until we start getting vaccinated, we still must follow these 4 W's. Wear masks, wash hands, watch distances, and walk away from groups. Don't stay in clusters of people, even if you are masked and even if you are keeping fairly good distances. Stay away from groups as much as you can. But we are learning again that this is far easier said than done. And now everyone's getting in a holiday mood, which brings these holiday challenges. During the holidays, there's asymptomatic transmission with imperfect testing. Complacency is a growing issue as people get tired of this virus, even though the virus is not tired of making us sick. There are exposures that can occur in transit as everyone travels about trying to get to somebody else's place to celebrate a holiday. And of course, we all worry about susceptible folks who are at home. Well, CDC and we suggest that there are these good tips to have as much fun as you can without someone ending up in the ICU on New Year's Eve. Limit your own household size. Limit people celebrating to your own household if you can. Keep to less than 10 people if you can. Celebrate outdoors if possible. Avoid hugs and handshakes. Wear masks. Maintain that 6-foot distance. Try to avoid alcohol, loud music, and singing, all of which get people to exhale harder, to breathe harder and faster, and expel more material into the air where other people can inhale it and get potentially infected. Minimize the length of time of celebration. Use plastic utensils, wipe down areas, and let's not forget, get flu shots. And yes, this is easier said than done. Do the best you can. Don't beat yourselves up, but really do try to be careful every step of the way. And yes, there is still some good news, because these rules work fairly well. And think about it. Have you been infected so far? If not, then empirically, what you've been doing has worked for you, at least so far. So don't push it. Keep your family COVID safe until vaccines and treatments arrive, because we're all in this together, but we still need to stay apart. Thank you.
Hello, I'm Dr. Shirlita Amler, Commissioner of Health in Westchester County, New York. Today, I will describe the public health authorities of the governor and local health commissioners with respect to COVID-19. I have no conflict of interest to disclose. Local health departments during the current emergency operate under special emergency powers, as well as their usual powers, as defined by New York public health laws and the state sanitary code. Following the World Health Organization declaration of the COVID-19 pandemic, the U.S. Secretary of Health and Human Services declared a public health emergency in this country. On March 7, 2020, with widespread COVID transmission, the governor issued Executive Order 29A, declaring a state of emergency that posed a risk to the health and welfare of New Yorkers. This executive order suspended and modified laws and gave the governor broad powers. Among these, requiring face coverings for anyone in public, including those on public transportation and at work, if they're over 2 years of age and medically able to wear a mask. Requiring social distancing, at least 6 feet apart in public, including at work. Defining what it means to be an essential worker or an essential business. Prohibiting non-essential social gatherings of more than 10 people, including on sidewalks near restaurants and bars. It also provided for civil and criminal penalties up to $15,000. Over time, this executive order expanded to travel restrictions and quarantines and the creation of yellow, orange, and red zones to specify what businesses may operate and under what conditions. Now, let's look at public health laws that operate outside the executive order. Public Health Law 2100 gives local health commissioners the authority to isolate a person with a communicable disease who poses a health risk to others. For people who test COVID positive, this means a 10-day mandatory isolation from exposing others and spreading disease. We ask that they have a bedroom and a bathroom where they can isolate themselves from the others that they might live with and not expose anyone else in the household. It also authorizes the quarantine of those who may have been exposed to a communicable disease but are not ill so far, but might be incubating the disease. And unfortunately, there's no way for us to tell when someone is incubating COVID until they go on to develop the disease. Public Health Law 2101 requires physicians, hospitals, and laboratories to report communicable diseases to their local health departments. There are approximately 100 communicable diseases that are required to be reported. This prompts case investigations to identify the origin of the infection and to discover whom it might have been spread to, in order to prevent additional exposures and illness. Public Health Law 12B established penalties for noncompliance with health commissioners' orders. Public Health Law 3082 provides immunity from lawsuits for good faith provisions of health care in response to COVID emergencies. Finally, an important federal law is 21 U.S.C. 3600 BBB3, which authorizes the FDA to issue emergency use authorizations for health vaccines, for drugs and vaccines, bypassing some of the usual requirements. When time is of an essence, when there is no available alternative treatment, and the potential benefits outweigh the potential risks of the candidate or vaccine. All of these laws enable health officials to act to protect the public, not just from common communicable diseases, unsanitary conditions in public facilities like restaurants and toxic oil spills, but also from new emerging health threats such as Zika, Ebola, and COVID-19. Thank you for your time.
Hello, I am Dr. Mil Etienne, Associate Professor of Neurology and Medicine here at New York Medical College. Today, I will go over some novel approaches to combating COVID-19 with special focus on a novel nasal spray that is currently being explored. I have no disclosures. We are approaching a year since the COVID-19 pandemic has made its way to our shores, and we are gradually putting the pieces of the puzzle together. There are numerous treatments that have been shown to be effective, and Operation Warp Speed promises to have a vaccine available to us in the not too distant future. At the moment, we have numerous therapeutics we are utilizing to combat COVID-19. I will briefly go over the basic categories. First, we have the monoclonal antibody, which is approved for use in non-hospitalized adults and children over age 12 with mild to moderate symptoms who have recently tested positive for COVID-19. Candidates for this treatment are those who are at risk for developing severe COVID-19. A single dose IV is administered within 10 days of developing the symptoms. Convalescent plasma. This is plasma containing COVID-19 antibodies from recovered patients. Convalescent plasma is a treatment that has been in use for over 100 years to treat a variety of illnesses, including measles, polio, chickenpox, and SARS. In the case of COVID-19, the donor plasma is given via transfusion to patients suffering from COVID-19. The donor antibodies may help the patient fight the illness, possibly shortening the length or reducing the severity of the disease. Researchers at the Mayo Clinic found that patients who have severe COVID-19 or are at risk of developing severe COVID-19 who received convalescent plasma within 3 days of diagnosis were less likely to die than patients who received convalescent plasma later in their illness. Other treatments that have been looked at include the antiviral remdesivir, steroids, vitamin D, and of course, there is now a great deal of interest in immunizations. The hope is that through Operation Warp Speed, this vaccine will be made available to the US in the not too distant future. There is a prioritization schema that is currently being worked out, which will dictate who in the US will be the first to be offered this vaccine. We now move to yet another novel approach to combating COVID-19, a nasal spray, which was recently featured in the New York Times. It has been well established that one of the routes of transmission of SARS-CoV-2 is through the nasal passages. A nasal spray is being tested by physicians and scientists at Columbia University, Vagelos College of Physicians and Surgeons to see if this nasal spray can block the entry of the virus into our system. The nasal spray is designed to block the absorption of SARS-CoV-2. The idea is that you would take a daily spritz into the nose, which would act similar to a vaccine, as it would prevent the individual from being inoculated by the SARS-CoV-2. So far, this theory has been tested in ferrets and has been shown to be promising. It has successfully prevented the virus from entering into the host cells. Ferrets are used for this type of study because the ferret's lungs are similar to human lungs. The compound in the spray is a lipopeptide that works by preventing a virus from fusing with its host cell membrane, a necessary step that envelope viruses, including SARS-CoV-2, use to infect cells. To fuse, the new coronavirus unfolds its spike protein before contracting into a compact bundle that drives the fusion. The compound designed by Moscona and Parado recognizes the SARS-CoV-2 spike, wedges itself into the unfolded region, and prevents the spike protein from adopting the compact shape necessary for fusion. The antiviral is easily administered, and based on the scientists' experience with other respiratory viruses, protection would be immediate and last for at least 24 hours. In the actual study, lipopeptide was delivered into the noses of 6 ferrets. Pairs of treated ferrets were then housed with 2 control ferrets that received a nasal saline spray, and 1 ferret infected with SARS-CoV-2. There was 24 hours of intense direct contact among the ferrets. Tests revealed that none of the treated ferrets caught the virus from their infected cage mate, and their viral load was precisely 0. All of the control animals were highly infected. Some benefits of the nasal spray include that it is inexpensive, easily administered, has a long shelf life, and does not require refrigeration. Additionally, because it is transportable and stable, it can be a key approach in rural, low-income, and hard-to-reach populations. These features make it stand out from other antiviral approaches under development. The new nasal lipopeptide could be ideal for halting the spread of COVID-19 in the United States and globally. This will be particularly helpful for patients who are not candidates for taking the vaccine. I am sure after you have heard about how great this nasal spray works and how safe it appears, everyone will be eager to go out and start asking their doctor to prescribe the nasal spray. Please be reminded that so far we only have animal data, and this has not yet been studied in humans. However, the scientists who have created this nasal spray are hoping to either work through Operation Warp Speed or with some of the major pharmaceutical companies to test this product in humans to quickly make it available for distribution here in the US and abroad. We will continue to follow this and other developments, and we will be sure to provide you an update on this possible treatment in the future. Thank you very much for your attention.
Hello, my name is Kathleen DiCaprio. I'm an assistant professor of microbiology and immunology at Touro College of Osteopathic Medicine, Harlem campus. Today, I will be presenting an update on COVID-19 vaccine developments and deployment. I have no conflicts of interest to declare. Now, scientific research and vaccine developments are continuing, with data being released about every month. Some vaccine data being released a bit more frequently. To give you a snapshot of where we are today, I've listed the top vaccine candidates here. So let's quickly review these as well as some recent updates. Let's first start with the Novavax inactivated vaccine, which was recently granted fast track status from the FDA, allowing it to enter into late-stage trials in the US later this month. Initial study results are expected to be released about early 2021, maybe sooner. The Sinovac inactivated vaccine is still ongoing, but has demonstrated antibody production within 28 days of the first immunization. However, the level of antibodies were a bit lower than that seen in people who were previously infected with COVID-19. Now, what this means as it relates to vaccine efficacy, we're not entirely sure yet, but the data on vaccine efficacy is still forthcoming. Now, the Johnson & Johnson adenovirus vaccine hopes to have data needed to file for authorization for its single-shot vaccine by January or February. Finally, Pfizer and Moderna, both with mRNA vaccines, have demonstrated at least an efficacy value of 90% or greater following its second dose of the vaccine. Additionally, AstraZeneca's adenovirus vaccine recently released data suggesting 70% vaccine efficacy, although this one is not as complete. So let's explore the data on these last three a bit more. Just as a quick review, each trial includes a 2-dose schedule with efficacy assessments set for about 1 to 2 weeks following the second dose. And this varies from vaccine trial to vaccine trial. Now, during the efficacy assessment, participants go about their daily lives. And if they start experiencing symptoms, they'll report it and subsequently get tested. So let's look at some of the data that's been reported recently. For the Pfizer vaccine, its analysis showed vaccine efficacy of 95%. The analysis included 170 cases of COVID-19. Of those, 162 occurred in participants who received the placebo. 8 occurred in those who received the vaccine. Moderna's trial demonstrated vaccine efficacy of 94.1%. The analysis was based on the development of COVID-19 in 196 cases. Only 11 of those confirmed cases were in the vaccinated group. The rest were in the placebo. Now, 30 of the COVID-19 cases were severe, and unfortunately, it did include one death. But all of those occurred in the group that received the placebo. Taking a look next at the AstraZeneca vaccine, which used the vaccine in 2 dosing regimens. Both involved 2 doses of the vaccine and examined 131 coronavirus cases. The regimen with the 2 full doses given a month apart showed 62% efficacy. Now, the first vaccination at half dose, followed by the full dose, produced 90% efficacy. However, the inclusion of the half dose was not actually integral to the protocol, instead a dosing error, which will likely require more formal revisions to its trial and likely delay it moving forward. But of those who received the vaccine, none developed a severe case of COVID-19. So what happens next? Pfizer and Moderna have submitted emergency use authorization, or EUAs, to the FDA. The FDA has scheduled meetings with its advisory committee on December 10th to discuss the Pfizer vaccine and around December 17th to discuss the Moderna vaccine. Now, the FDA didn't say how long its review will take, but government officials are aiming for year-end commercialization by the end of the year. That's right around the corner. Operation Warp Speed representatives are hoping to begin shipping a vaccine maybe before the end of the month. Now, the AstraZeneca vaccine has a bit more work to do to address some of those dosing regimen issues, but it may be moving a bit more quickly in the UK. Now, it is important, however, I got to mention that although these vaccines are close to discussions about deployment, these trials are not yet over. There's still data to be gathered and analyzed to address the several objectives and endpoints that are outlined in each of these clinical trial protocols. What else do we know? What about the short-term side effects? Well, we do know that local and systemic adverse reactions have been demonstrated. They're listed here. And they mostly last about a day after each injection. They include pain at injection site, fatigue, muscle ache, headache, also fever. In some cases, the symptoms were actually a bit more intense after the second shot. Now, although the safety data so far has met standards to submit the EUAs, we still have questions about long-term effects. So what do we know about this point? So far, the reactions are mostly just short-term. The data is only available, though, on adverse effects for the period of time that the vaccine has been given. Another really important question to ask, what do we know about how long these vaccines last? Recall that the vaccines have been tested only for a couple of months now, so it's a bit too early to know how long they will be effective for. This data will be pivotal to the long-term COVID-19 vaccination and public health planning. Yes, there are still questions that we have about all of these vaccines. And so as a conclusion to the presentation, I'd quickly like to delineate some of the several additional forthcoming data that should help continue to answer these questions, but possibly also raise some more. Some forthcoming data include just looking at final efficacy data on vaccines in severe COVID-19 cases, looking at efficacy in the younger population, for example, 12 to 15-year-olds, vaccine efficacy data related to whether or not these vaccines are effective in patients who had previous infections with SARS-CoV-2, various age groups. What about after the first dose? And looking at the severity of or absence of COVID-19 in patients infected with HIV. The recent encouraging data does provide some hope that a vaccine or vaccines are coming soon. So as we continue to wait, hang in there. I know I am. Thank you.
Hello, this is your host, Dr. Edward Halprin, to remind you that if you wish to get CME credit for today's webinar, text the code 22SLOB to 828-295-1144, or go to our website, www.eeds.com, click the sign-in button, enter the same code, in all capitals, SLOB, and you'll get the information as to how to fill out your satisfaction questionnaire with today's webinar and to get your CME credit. We hope that many of you will consider supporting projects like the COVID-19 webinar you're listening to today with a tax-deductible gift at the end of the calendar year. These webinars and the free CME credit, of course, don't come for free to the college. We have real expenses in putting on these programs. Please consider visiting our website, www.nymc.edu/give, to support today's webinar. And for those of you who prefer writing checks can be made payable to New York Medical College. Write the word COVID-19 webinar on the memo line of your check and mail it to the Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, zip code 10595. And now let's return to our program.
My name is Tammy Hendricks, and I'm a professor of pediatrics and the Associate Dean of Academic Affairs at Touro University, California, College of Osteopathic Medicine. I will be speaking to you today about pediatric developmental issues and concerns due to our current COVID-19 pandemic. I have nothing to disclose for this presentation. One of the lessons that we learned early on in this pandemic is that masks help to mitigate the spread of the virus. With the general public, parents, teachers, and childcare providers all wearing masks, the question that comes to mind is, what is the developmental impact of masks on infants and young children? Research has shown us that children under the age of 12 may have difficulty in recognizing people in masks because they often focus on individual facial features. A lot of our emotional information is demonstrated in the movement of our facial musculature. Masks that cover our faces lead to issues with emotional recognition and social interaction. Additionally, children may have problems with speech recognition. Even though we tend to think of speech communication as taking place through sound, a great deal of information is also communicated visually. Around the age of 6 to 8 months, as babies start to babble, they change the ways that they are looking at people who are speaking to them. Instead of concentrating on the eyes, they spend a lot of time looking at the person's mouth, getting both auditory and visual cues. The research shows that although young infants and adults look most at a person's eyes when they are speaking, children between 6 months and 5 years tend to be the most interested in the mouth. In order to decrease the developmental impact of masks and to help individuals who rely on lip reading, there have been a number of calls for the use of clear masks to help decrease the spread of the virus while also allowing people to see those important visual communication cues. Masks may not be the only negative impact on development of young children. As daycare centers have closed and more parents are moved to working from home, we see a big increase in the amount of distractions at home. In this way, infants and young children may be missing out on that vital face-to-face time with their adult caregivers. While children typically pay attention to people's mouths while they are talking, it's by far not the only cue children have to communicate and learn. There are studies that show that children are able to read facial emotions just as well when a mask is added. I can say anecdotally that in my clinical practice, infants as young as 2 months old will return my smile, even when my face is covered with a face shield and an N95 mask. Indeed, we see that voices, gestures, overall body language are all important for children. Additionally, parents won't be in masks all day, and being covered for a few hours every day isn't likely to make children less able to recognize social expressions. There are things that teachers and caregivers can do to help decrease the potential negative social, emotional, and developmental impact of wearing masks. We can take lessons from best practices of working with children on the autism spectrum and with developmental delays. Teachers and caregivers should be verbally explicit when they are masked. They should state their emotions out loud and teach children to do the same. Studies show that children get better at recognizing social emotional cues from the eyes, body language, and tone of voice. Based on the results of these studies, it's recommended that attention to nonverbal communication skills can make a positive impact on the future of a student's life. There are some cultures and countries that have significantly more extensive mask use than we do. This is often due to concerns about the risk of other viruses and pollution. There has been no evidence that demonstrates that children growing up in these areas are any worse at recognizing faces or emotions. We have mainly been focused on the developmental impact of masks. Another big concern for the developmental impact is that of school closures. Schooling provides essential learning, and when school closes, children are deprived of opportunities for growth and development. The disadvantages are disproportionate for underprivileged learners who tend to have fewer educational opportunities beyond school. Many children rely on free or discounted meals provided at schools for healthy food and nutrition. When schools close, nutrition is compromised. It is a challenge to ensure children return and stay in school when schools reopen after closures. This is especially true of protracted school closures and when economic shocks place pressure on children to work and generate income for financially distressed families. We have seen significantly increased rates of non-accidental trauma, abuse, and neglect. For some students, school is the one safe place that they can escape to. Additionally, more time online may expose children to an increased risk of sexual exploitation and bullying. Schools are hubs of social activity and human interaction. When schools close, many children miss out on the social contact that is essential to learning and development. As a result, we see higher rates of depression, anxiety, and suicidal ideation. The pandemic has exacerbated well-documented opportunity gaps that put low-income students at a disadvantage relative to their better-off peers. For online learning to be successful, you need to have access to a computer, reliable internet, and a quiet, safe place to learn. These are not available to all children. Luckily, we know how incredibly resilient children are. As communities learn more about the risks posed to children, they are developing creative and innovative ways in which children can learn and thrive in safe places that protect them from the virus as well as other harm. The research on learning and memory shows that learning is possible and memory can be enhanced across the lifespan. Neuroplasticity, the way the brain changes across the lifespan, is the mechanism that powers the possibility of change and growth over time. Children are known to have high levels of that plasticity. Thank you.
Good afternoon. I'm Marissa Montecalvo, and I've been asked to speak on this question: are we on the verge of having millions of Americans with a new pre-existing condition? I have no conflicts of interest to disclose. So I like to always go back to the beginning. This is one of the first articles in the New England Journal of Medicine describing 3 patients with pneumonia from China on January 27th. Here you can see this respiratory illness in the radiograph that's projected, clear bilateral pneumonia. And now we're asking, are there potential sequelae of this infectious disease? So in thinking about chronic sequelae of microbiologic infections, I think that these can be grouped into 4 categories. Firstly, you can have just persistent infection, which may be dormant for periods. We see this with herpes viruses, and in some cases, there are cancer associations with these infections, as with Epstein-Barr, Hep B, human papillomavirus. Secondly, you can have complete resolution of infection, but still have lingering symptoms. Third, the infection may cause organ involvement with organ damage that results in chronic symptoms. And lastly, as in the case with Guillain-Barré syndrome and the association with Campylobacter, you can have immunologic sequelae that result in disease manifestations. In the case of SARS coronavirus 2, I don't think we have any evidence of persistent infection at this time. But the other 3 categories, I think, are all open for discussion. So the Centers for Disease Control has recently published a framework to begin thinking about the potential chronic sequelae of this infection. So if we start with the acute infection, you're all very familiar with that, where one tests positive by PCR, and antibody is usually recoverable within about 2 weeks after the onset of symptoms. Secondly, there has been a post-acute hyperinflammatory illness that has been described initially in children, where there appears to be a dysregulated host response. And this is predominantly extrapulmonary with gastrointestinal, dermatologic, and neurologic symptoms. These children are antibody positive, but may not have SARS coronavirus 2 detectable by PCR. These are small series. It is not a common syndrome. It was initially described in children and is now also being described in adults. And lastly, are late sequelae, which are the least well understood of persistent symptoms. So I just want to call to your attention this publication by Dr. Dufort of the New York State Department of Health, where our State Department of Health looked at patients, at children with the multisystem inflammatory syndrome. These were 99 patients. They were all antibody positive, and a little over half had SARS coronavirus 2 detectable by PCR. And here you can clearly see the predominance of dermatologic and gastrointestinal manifestations. 48% had a Kawasaki disease-like syndrome, and then also myocarditis and neurologic involvement. This is a syndrome that affects young children, but can also be present into the teenage years. What about lingering symptoms? So this is an area that is of great concern and has been described as the long hauler. So fatigue, dyspnea, cough, arthralgias, chest pain, and loss of taste and smell can all persist after the patient is off isolation and what we think would normally be the resolution of infection. Of concern, we always are concerned about older patients and severe complications, but lingering symptoms have been well described in young patients with mild illness. And complicating this is the deconditioning and lifestyle changes that occur during COVID-19 infection. So sometimes it can be hard to sort out some of these symptoms. I want to call to your attention a study from Italy where they looked at 143 patients and interviewed them 60 days after onset of symptoms. Now, in Italy, to exit isolation, you have to be PCR negative ×2. So that's different from the United States, where we use a symptom resolution strategy to complete isolation. So these patients stay on isolation longer. Their mean age was 56 years, and at 60 days, only about 13% were completely symptom-free. And again, the predominant symptoms were fatigue, dyspnea, joint pain, and chest pain. The CDC has done a telephone survey of young persons a little over 2 weeks after infection, and 20% had lingering symptoms. So there are clinical trials going on to study this. In the United States, there's a longitudinal study of COVID-19 sequelae and immunity. And also in the United Kingdom, there's a very large study going on looking at predominance of symptoms after resolution of infection. Lastly, what about organ involvement? And could it be that organs are involved and this is not resolving, and that's what's causing the chronic symptoms or sequelae? So there are 3 areas here that for which there have been several publications: cardiac, pulmonary, and neurologic. Now, the cardiac manifestations were described actually at a prior Toro Symposium on COVID-19. It was a study in Germany looking at 100 patients that had MRIs approximately 71 days after their diagnosis, they all had elevated troponins. 78% of them had abnormal MRIs, with 60% showing myocardial inflammation. And this was a relatively young group with a median age of 49 years. So that's concerning, what is going to happen with these kinds of findings. Closer to home in the United States, a study of 26 college athletes, all of whom had mild disease, half had myocardial injury evident by MRI. And this has led to registries for athletes to be followed and to try to understand what the sequelae of this will be. In China, there have been studies looking at ongoing pulmonary manifestations. Decreased diffusion capacity has been documented both 30 days and 3 months after discharge, and reduced respiratory muscle strength. And lastly, the neurologic sequelae, which are manifest often by headache, vertigo, or chemosensory dysfunction. There have been descriptions of a quote unquote brain fog, where people just don't feel like they're back to norm. They just don't feel sharp. There may be sleep disturbances associated with this, and it may be further complicated by just the combination of neurologic and psychological and psychiatric sequelae associated with this disease. So in answer to the question, are we on the verge of having millions of Americans with a new pre-existing condition? Obviously, I don't know the answer to that, but I think what we do know is that there is a subset of patients. It's small, but there is clearly a subset of patients with a multi-system inflammatory syndrome that appears to be immunologically mediated. There are persistent symptoms that can occur even a few months after illness onset, and these cohorts need to be well studied. And lastly, the resolution of cardiac, pulmonary, and neurologic symptoms also require long-term follow-up. Registries of patients will be essential to truly determine what these long-term sequelae are. Thank you very much. These are my references.
I'm Neil Schluger, Chairman of the Department of Medicine at New York Medical College and Director of the Department of Medicine at Westchester Medical Center, and I'll be discussing drugs for the treatment of SARS-CoV-2 COVID-19 illness. Does anything work? I have no conflicts of interest to disclose. At the beginning of the epidemic, the COVID-19 epidemic, there were a fairly long list of drugs that were proposed for treatment of COVID-19 illness, mostly in two categories: direct-acting antibiotics or antiviral drugs, or anti-inflammatory drugs that were aimed at dealing with the severe side effects or complications of COVID-19 infection. I'm going to focus my remarks on hydroxychloroquine and remdesivir, two of the drugs that have gained the most interest in this disease. Now, the usual way we like to evaluate drugs for any treatment is through the use of randomized controlled trials. And randomized controlled trials are really at the apex of a hierarchy of ways of collecting medical evidence. And when a company comes to the FDA seeking approval for a new drug, the FDA usually insists on data from at least two independently done randomized controlled trials as the highest standard of evidence. Randomized controlled trials, though, are difficult to do under any circumstance for many reasons. They're very complicated to design. They have all sorts of logistical issues that have to be dealt with. You need specialized personnel to conduct them. There are regulatory and administrative issues that have to be dealt with, contracts that have to be written, approvals that need to be obtained. They're expensive, $15,000 to $40,000 for every patient enrolled in the trial in general, and they take a long time. During an epidemic, it's even harder to do randomized controlled trials because the system is just overwhelmed with patient care needs. We certainly saw this in the New York area in the spring with COVID. The environment in many hospitals was bordering on chaos, and it was really all hands on deck, and there weren't many people available to do research studies. Physicians might lack equipoise. Another way to say that is that they might be biased. Physicians might believe that they know or they feel strongly that a certain drug is going to be effective, and they may be unwilling to put patients into trials. And then patients themselves might be unwilling to participate. They come to hospital with an expectation of treatment, not an expectation of being put into a research study. They may have mistrust of the research enterprise for a variety of reasons, and they might be influenced by lay sources of information that they hear about on social media, through the internet, on television, and in other places. So these are some of the challenges. So it was in this context that hydroxychloroquine was proposed as a treatment for COVID-19. There were early reports from France and China that this drug and its close cousin, chloroquine, might be useful in the treatment of COVID-19 illness. These were drugs that have been used for many years, mostly to treat malaria. But there were a few very small and generally poorly designed and poorly conducted studies that suggested that hydroxychloroquine might be useful in COVID. And based on that little bit of evidence, many hospitals and professional societies recommended these drugs in COVID illness, and they were widely used early in the pandemic in the United States and elsewhere. At the time, in the spring, I was working at Columbia University Medical Center as chief of the Division of Pulmonary Allergy and Critical Care Medicine, and our hospital was administering hydroxychloroquine. And I put together a group of investigators to examine the effectiveness of this, not through a randomized trial because we had just been giving it, but through a retrospective cohort analysis that we did using sophisticated statistical methods, including Cox regression and propensity score analysis, an attempt in a sense to retrospectively create a randomized trial as best we could. And we did this and published it in the first week in May in the New England Journal of Medicine. And what we found, you can see on the right-hand side of this slide, I think very clearly, that there was no difference in outcome between patients who received hydroxychloroquine and patients who didn't. We found no association with hydroxychloroquine administration and any difference in death or rates of mechanical ventilation. And this paper got an enormous amount of attention because it was the first large study to say that hydroxychloroquine perhaps didn't have any beneficial impact. And it was followed quite quickly by a number of randomized controlled trials that confirmed our finding in a variety of clinical settings in patients who are already ill, patients who had just been exposed, and these several randomized trials found no effect of hydroxychloroquine, and it seemed as though the issue had been settled at that point. However, later in the summer, this paper was published in the International Journal of Infectious Disease, received a lot of attention, a study from Henry Ford Hospital that claimed an enormous reduction in mortality associated with hydroxychloroquine. Now, any first-year student in epidemiology could have poked holes in this study and found the flaws. And I've listed some of them here. Patients who got hydroxychloroquine were quite different from patients who didn't in ways that really could have biased the results. Yet this study got a lot of attention and was tweeted about, including by this congressman from Arizona who encouraged the president to take hydroxychloroquine when he was hospitalized with COVID-19 illness a few months ago. The president did not take this, as far as I know, but many people were still pushing it. Finally, a very large study was published in the New England Journal of Medicine from the UK, where nearly 5,000 patients were randomly assigned to hydroxychloroquine or a placebo. And you can see here there was absolutely no difference in terms of mortality. And I think this study put the final nail in the hydroxychloroquine coffin and settled the issue. Now, what about remdesivir? Remdesivir, an antiviral drug originally developed to treat hepatitis C and Ebola, not effective in those illnesses, but there was some thought that would be effective in COVID. An early study, a randomized control trial, showed no difference in time to recovery in patients with remdesivir compared to patients treated with placebo. And in that study, the amount of virus in the upper or lower respiratory tract was no different in patients following treatment with remdesivir compared to patients with placebo, so a negative study. However, then Following on that, a larger randomized controlled trial published in the New England Journal of Medicine suggested that patients who received remdesivir recovered slightly more quickly, 10 days instead of 15 days, than patients who received placebo. There was no statistically significant difference in mortality, however, in that study. And then most recently, a very large trial sponsored by the World Health Organization enrolled 11,000 patients totally in 405 hospitals in 30 countries. And within that study, there were nearly 3,000 patients who received remdesivir, and 4,000 patients who received placebo. And you can see in terms of mortality, absolutely no benefit at all in patients receiving remdesivir. So what do we have with these two drugs altogether? Three groups have been making recommendations about treatments for this: an NIH expert panel, the Infectious Disease Society of America, and the WHO, the World Health Organization. All of them recommend against using hydroxychloroquine. So there's unanimity of opinion there. Remdesivir, there is some disagreement. In mild to moderate illness, the NIH takes no position about whether the drug should be used one way or another, recommends it in severe illness. The Infectious Disease Society recommends against it in mild to moderate illness, but recommends using it in severe illness, and the WHO recommends against it in all circumstances. So that's really the state of play with these two drugs, and I'm happy to take any questions later on if there are any.
Hello, this is your host, Dr. Edward Halpern. For those of you seeking CME credit, text the code 22 and then all capital letters SLOB to the phone number 828-295-1144, or go to our website, www.eeds.com, click the sign-in button and enter the same code, and you'll receive instructions as to how to fill out your satisfaction questionnaire and instructions as to what process to follow and which boxes to click on to get your CME credit, which will arrive electronically. We hope that some of you will consider supporting our webinar program and the provision of CME credit by going to our website, www.nymc.edu/give, and making your tax-deductible donation for the support of programming such as you're listening to today. For those of you who prefer to write a check rather than going to the online site, checks can be made out to New York Medical College and right on the memo line for support of the COVID-19 webinar, and send it to the Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, zip code 10595. Thanks for considering supporting programming like you're listening to today. And now it's time to turn our attention to the question and answer portion of the program. If you haven't typed in a question yet, go to the question and answer section on the bottom of your screen to type it in, and we'll be monitoring what you type in. Our question and answer program will be moderated by the president of the Touro College and University System, Dr. Alan Kadish.
Thank you, Dr. Halpern. We've had a lot of great questions, and we'll try to get through as many as we can in about the next 25 or so minutes. The first question is for Dr. DiCaprio. There's a lot of concern that two of the vaccines that you talked about, the one from Pfizer and the one from Moderna, are based on new technology, an mRNA vaccine that has never been used before. What are your sense about possible unknown long-term risks of these two vaccines? And should people be concerned about receiving these vaccines because of the new technology and the potential risks?
These are great questions, and they're questions that I have as well. And at this point, as I mentioned, the long-term effects of these vaccines, or really any of the vaccines that are being tested, we just don't know yet because they've only been tested in part in clinical trials for several months now. And so the long-term effects, depending on how you define long-term, we're just going to have to sit back and wait and see what comes of that. The silver lining here is that the short-term effects are very mild. And so, based on that information, just those short-term effects being very similar to many of the other vaccines that we received, like the flu vaccine, demonstrate just the boosting of our immunity. I should point out that these mRNA vaccines, while they are new as commercially available vaccines, they're not unknown. This technology has actually been around for many years now. In fact, these the mRNA vaccines, including the nanoparticle technologies that kind of provide that protection of the vaccine to be utilized as a vaccine, has been around for many years. There are current experimental vaccines using the same technology against Zika, cytomegalovirus, rabies. In fact, they're even using that same technology as a means of generating protective immune responses against cancer. So there is a lot that we do know about this technology that's been tested in animals and shown a lot of promise, but this is our first experience with it being used in humans. So unfortunately, it's something we're just going to have to wait and see. Oh.
Sorry, we're having a muting issue. That's very helpful, Dr. DiCaprio. So do you think people should hold off on getting the vaccine, or would you suggest taking it once it's available, given that you've said you don't for sure know about the long-term risks?
Yeah, and you know, that's a great question, and that's one that I think it just comes down to personal, personal preference. I can be honest in telling you that personally, I'm more than happy to stand in line to get that vaccine myself. I've used that technology in animals for experimental purposes, and I've personally seen the effects of that technology in various forms in animals, and it's shown no safety problems for much worse viruses than COVID-19. That's my personal preference, but I think that the beauty of being in the United States of America is that hopefully we will have the option to choose. And the other good news is that the Johnson & Johnson vaccine, the AstraZeneca vaccine, they are different platforms that we do have vaccines against, which is the adenoviral vector platform. They are not too far behind these, and they show also good safety profiles as well. And so it may be that in a couple of months, we may have options as individuals to choose the vaccine that we can get.
That's great. Thank you. The next question is for Dr. Robert Amler. It's one about masks. The question relates to N95 masks, but I would sort of expand that to say, there are paper masks, there are cloth masks, there are N95 masks. Do you think one is better than the other? Is it just a question of what you can get? What advice do you have about, you've said masks are really important. What advice do you have about which mask to use if you have a choice?
Sure. For those of us in the general public, the basic cloth or paper surgical mask is the one that's most being used because it is most widely available. It causes less difficulty in terms of being able to breathe for long periods of time. The basic mask that almost everybody wears prevents the exhaled breath out of your mouth and nose from getting out into the air around you, where other people can inhale it and potentially get infected. The N95 mask is a much tighter mask. It is harder to breathe through. In fact, if you can breathe easily through it, you're not wearing it properly. And this is intended to also protect the wearer against small particles that might carry virus into your nose and mouth. So for most people, the regular mask, if it's cloth, several layers are better than just one layer. And for healthcare providers, not just an N95 mask, but also a face shield to prevent eye exposure to your eyes is preferred. Thank you for the question.
Sure. So the next question is for Dr. Schluger. You talked a little bit about the data about hydroxychloroquine. Some have suggested that the combination of zinc with hydroxychloroquine can have additional efficacy. What's the status of those data? And given what you've shown us about remdesivir and hydroxychloroquine, are there other therapies you think can really that we now know will make a difference in treating coronavirus?
Right. Thanks very much, Dr. Kadish. The question about zinc has also come up in the chat a few times. First thing to address is whether it's really believable that zinc has important antiviral properties in any circumstance. There's not a tremendous amount of data that it does, although there is some data from pediatric populations that zinc deficient children who are repleted do have somewhat lower incidence of diarrheal illness and acute respiratory tract infections. But in well-established serious viral infections, there's very little data to suggest that zinc is really effective. To date, there have been no well-done randomized control trials in patients with COVID-19 illness that have been reported that suggest that zinc in combination with hydroxychloroquine, with or without azithromycin, would be effective. So no one is recommending that at the moment. Those trials, as far as I know, there are trials like that that have been started. Whether or not they ever get finished, we'll have to see. But no, there's no recommendation from either NIH, the Infectious Disease Society of America, or the WHO to use zinc. Remdesivir, as I mentioned in the talk, the data are somewhat conflicting. I think what one would say is that remdesivir probably helps some patients a little bit. It's not a miracle. And at the moment, there's nothing really on the horizon, I think, that looks like it's going to be a game changer.
Thank you, Dr. Schluger. The next question is for Dr. Etienne. And the question is, can a person have long-term cognitive injury as a result of COVID-19 infection? We've talked a little bit about the neurologic findings. What do we know? Obviously, it's early, but what do we know about the long-term effects of neurologic damage?
Sure. Thank you for that question. So patients with more severe COVID-19 may have long periods of not getting enough oxygen to their brain, which could lead to injury of their brain cells. Now, these patients with more severe COVID-19, they could have obvious cognitive deficits, like being comatose in a long-term care facility. However, a study was done looking at the milder cases of patients who have recovered from COVID and found that the cognitive impairments actually do exist even in these patients who have recovered. And the thought is that this may be linked to the inflammatory processes. But the one study that I've seen only had about 29 patients that they've looked at. So obviously we're looking to see more data come out over time.
That's great. Thank you, Dr. Etienne. Appreciate that. The next question is for Dr. Montecalvo. If you've been exposed to an infected person, but have 2 negative antigen or PCR tests, do you still need to quarantine? And if so, why and for how long? And perhaps you could also review the recent changes in the quarantine recommendations.
Thank you. I'm so glad someone asked that question. Thank you, Dr. Kadish, because the quarantine issue has gotten a lot of publicity over the last couple of days. So the first part of the question being, if you test negative during your quarantine period, do you need to complete your quarantine? And the answer to that question is yes. So the concept behind quarantine is that you are to remain in quarantine throughout the incubation period. And right now, the incubation period remains at 2 to 14 days. So you can't test out of quarantine. You can just, testing may be beneficial to you for various reasons, but it doesn't change the duration of quarantine. This is easy to it can become very confusing because in New York State, when you're on quarantine for travel, you can test out. So when we're talking about being on quarantine in the 14 days, we're talking about quarantine because you've been exposed to a person who has COVID-19. When you are on quarantine because you're on a travel associated quarantine, that's a different situation. And there were changes by New York State about a month ago, which have allowed people to follow a testing program where you can test out of quarantine. In relation, though, to the 14-day quarantine for exposure to a person with SARS coronavirus 2, the Centers for Disease Control and Prevention has recently brought up again the issue of whether they could reduce that quarantine to 10 days or even 7 days if one tested negative. And that is being put forth because the thinking is that perhaps there would be greater compliance. But I want to be very clear that these are recommendations, and the rules surrounding quarantine and isolation are state-based. And we are governed by the New York State Department of Health, not by the CDC. And currently in New York State, we remain with 14 days of quarantine after exposure to an infected person. New York State, historically through this pandemic, has been very slow to adopt any CDC recommendations. So, I don't know what they'll do. I certainly can't predict what the governor will do. But right now we're certainly in the at the 14-day quarantine post-exposure.
Thank you very much, Dr. Montecalvo. The next question is for Dr. Hendricks. The question relates to the possibility that COVID-19 infection during pregnancy might produce some long-term adverse effects on the fetus, such as other viral infections have shown. And related to that, what about potential risks to the fetus if you get vaccinated during pregnancy? So is there a risk of the disease, and is there a risk of the vaccine?
Thank you. Those are excellent questions, and ones that definitely still need more study. We do know that COVID-19, pregnant women are at risk of more severe complications with COVID-19. So they can have longer stays in the ICU, need intubation, just have experience a worse sickness from the disease. So far, we haven't seen too many direct effects on fetuses. There has been an association with potential increased risk of premature delivery. The World Health Organization has come out and said that they haven't been able to find the active virus in either the amniotic fluid nor in breast milk of pregnant women who are affected or infected. So, so far we need more studies, and there are active studies going on right now to look at these long-term impacts. And for the immunizations, I think once again, we'll need to really study those immunizations before we can make any clear statement about whether or not it's going to negatively impact the fetuses.
Thank you, Dr. Hendricks. We now have another question for Dr. DiCaprio. Can you still harbor and spread COVID-19 after you've been vaccinated? And I'll sort of elaborate on that. How soon after vaccination are you protected from getting the disease or from spreading the disease?
Those are two great questions, and they're actually kind of integral to each other. After you've been vaccinated, can you still spread the virus? And we don't know that yet. We only have a very small pool of participants, even though that it is a large number of participants in these clinical trials. It's still so early in the phase 3 that we're not entirely sure yet what those outcomes will be. We do know that with the good news is that with a vaccine efficacy value at that level, I mean, these vaccines, the Pfizer and Moderna vaccines, it's greater than 90%. That is very impressive in terms of vaccine efficacy, that the likelihood that these vaccines are providing very strong, robust, and full immunity to these virus is very likely. And so the likelihood of someone who is able to generate that type of immunity to the virus, it is unlikely that they're going to spread the virus. Now, we don't know, so this is just something that time will tell, but it's important to consider a few variables that all of these clinical trials are actively exploring. And so in time, we will get answers to this because they're generating data. The first is, what about people who don't respond to vaccines? There are some people that just don't respond. What about, how long does the vaccine last? As I mentioned in my presentation, we don't know. Is it weeks? It's more than weeks, we think, because of the trial. But how many months is it? Could it be years? Could this be many, many years? We just don't know yet. But I think in my opinion, one of a really important question is the issue of doses. When we look at the Pfizer and the Moderna dose, they require 2 doses. And so I think an important question that needs to be answered, and we need information on this, is what happens after the first dose? Because in a couple of weeks, it looks like our healthcare providers hopefully are going to be vaccinated with one of these vaccines with 1 dose. What happens in that month that they're waiting for their second dose? So those are answers that we still need to wait to see if that immunity that they generate will be protective fully, number one, and will they be able to spread it?
Thank you very much. Next question is for Dr. Robert Amler. There was a lot of concern early on that the virus might be transmitted by touching objects. And it seems there's been some work that suggests that's less of a danger these days. Can you update us on what we know about spreading the virus by touching and what precautions should be taken, say, when ordering food or in stores and things like that?
Sure. Thanks for the question. It's a good one. Everybody's concerned about touching things, touching their face, and so forth. Let's face it, the real mode of transmission here is through the air and through droplets traveling through the air where they can be inhaled. When droplets land on surfaces, some cling, some dry out, some get sloughed off or blown off, but if you're concerned, you can wipe them off. We learned even in the first Touro NYMC seminar at the end of January that the capsule on the virus particle itself makes it quite susceptible to wiping because the capsule has a stickiness to it that causes it to be easily wiped away. The best defense against virus on surfaces is to wipe surfaces off, to avoid touching surfaces, and to use hand sanitizer or just plain soap and water for 20 seconds so that you frequently wash your hands and avoid recontact with possibly some virus. But the big risk is the air and the droplets. Thank you.
Thank you very much, Dr. Amler. We're now back to Dr. Schluger. Early in the pandemic, there was talk about blood type influencing the severity of disease. Have those data held up, and are they robust enough to really make a difference in terms of risk in clinical situations?
Right, so that's really a fascinating question. And the answer is that it does look as though from now large studies that are fairly robust, that there is some difference in susceptibility, either susceptibility or to severity of disease in people who have been infected, that there are some differences that are related to blood type. And specifically, it's been suggested that people who are blood type O, when controlling for other factors that we know affect clinical severity of illness, like age or comorbidities, that persons of blood type O seem to have more mild illness. There have been other genetic components that have also been identified as perhaps being protective through large genome-wide association or GWAS studies. But what I would say is that although I am one of the people who's probably happy to imagine that blood type O is protective, it is certainly not the equivalent of protecting you against the kryptonite that is COVID-19. And if you know your blood type O, by no means should you be less vigilant about wearing a mask, keeping your distance, washing your hands, and doing all the other things that protect you against COVID. So it's a very interesting signal. There may be interesting information there about the mechanism of illness, but at the moment it doesn't provide any useful information about people with one blood type or another about how they should behave or be treated.
So are there any hypotheses that kind of are easy to get one's hands around about why blood type might make a difference?
I don't think for blood type. There are for some of the other genetic markers, things related to angiotensin converting to enzyme genes, which is the receptor through which COVID binds to surfactant producing cells in the lung, for example, that are a little easier to understand. But I haven't seen a really compelling hypothesis related to blood type.
Thank you. Then there's a question about post-polio syndrome, and should we be worried about very long-term consequences of COVID-19? Dr. Montecalvo, maybe you can take a stab at that, and then perhaps I can say a word about what one of our guest speakers earlier this afternoon, Dr. Peter Libby, said about cardiac long-term effects of COVID-19. So go ahead, Dr. Montecalvo. Would you be concerned about things like post-polio syndrome and long-term effects? Is there any way to know at this point in a disease that's only less than a year old?
Well, the second question's easy to answer. There's no way to know. So thank you for the question. So, it's long-term sequelae of infectious diseases are not that common, right? It's really, the disease, it's really the organisms that have the capacity to remain dormant somewhere. And in the spectrum of organisms, that's it's a substantial, but not an overwhelming group. So right now, it doesn't look as though that there's a reservoir somewhere, but long-term effects can be either microbiologic or immunologic. So no one really knows. One thing though, in thinking about that to consider is that because this is a highly communicable disease, persons who have had SARS coronavirus 2 are actually in the public health databases of each of the states where they live. So hopefully down the road, if we see some unusual manifestation of something going on, we would be able to know whether that person had SARS coronavirus 2, because these are all reportable infections. So just like knowing whether someone had syphilis 30 years ago, those data exist. And now in the world that we live in with the IT capacity, that should be much, much easier than it was for syphilis. Thank you.
Sure. So thank you. And it certainly seems like it's something we ought to look at in the future. I said I'd say a word or two about the cardiac effects. It seems like a lot of the cardiac effects are due to vascular disease and inflammation, and perhaps small amounts of damage to heart muscle. But what's a little concerning about long-term cardiac effects is we know from studies of other kinds of cardiac disease which primarily affect the heart muscle, at least, that there are some long-term adverse consequences that we didn't fully appreciate previously. So I think looking for long-term cardiac effects is one of the reasons to be careful, because there are a few young people who didn't have such severe cases who still had abnormalities on careful cardiac testing, although whether the extent of that was exaggerated by one of the early studies is still unclear. And so I think that's another reason to be careful about COVID, and also something we're going to have to look at in the long-term future. So last question, I thought ought to be about vaccines for Dr. DiCaprio. The last question is, should we worry about vaccine resistance or virus evolution decreasing the efficacy of these great rates of 94.5% efficacy? How big a problem do you think vaccine resistance or virus mutation might be in maintaining long-term efficacy of vaccination programs?
This is a great question. This is something that many people around the world are actively monitoring, and they're monitoring it very closely from an epidemiological point of view, as well as proteomics and genomics. We know that there are very, very, very minor mutations in different isolates throughout the globe, and those are being monitored. Regarding the vaccines in the specific immune response that they generate, they all seem to generate an immune response against the spike protein, but the epitopes that they're generating that response for, these are the very, very, very small pieces of that protein are different. So we do have that diversity in terms of what on the spike protein. We also have different vaccines. Some of these vaccines are generating an immune response to the entire spike protein. Ooh, my arms just went away there with my virtual background. But some of them are also very small pieces. So the vaccines themselves are going to be generating a very robust diversity of immunological responses. And I think that is something to consider too, as a benefit to having so many vaccines moving into the market right now that are safe and effective. Regardless of their vaccine vaccine efficacy, because each of those vaccines has a different target in terms of the small proteins, they will help create that diversity in conjunction with people who aren't being vaccinated, because it's highly unlikely that 100% of our world is going to get vaccinated. So we will have that level of herd immunity, hopefully. And so there's lots of variables to help with that, but we're still watching it, and it is a concern. And those are definitely things that many people and many researchers across the globe are watching very closely.
Thank you very much, Dr. DiCaprio. So I want to thank the speakers for a great program, the audience for a bunch of great questions, and echo Dr. Halpern's ask that if you can help support our program so we can continue to work on educating the public, creating these webinars and doing the work of the Center for Disaster Medicine at New York Medical College, your help would be greatly appreciated. Thank you very much. Have a great day. Stay safe and enjoy the holidays. And perhaps we'll see you back in January, depending on how the pandemic goes. I hope not, but the likelihood is there'll still be a lot to talk about then. Take care and have a good night.